Everyone to Einstein's Eyes, our YouTube channel, John and I created. We are proud. We are growing a little bit, which is fantastic. I am Carl Rosen. I'm in Anchorage, Alaska. Yes, there is snow outside, and yes, it is cold. I'm an oculoplastic surgeon and neuro-ophthalmologist, although really focusing on oculoplastics lately. My colleague, co-resident back at Albert Einstein many years ago is John. John, introduce yourself.
Hi, I'm Jon Ditkoff. We both trained at Albert Einstein, hence Einstein Eyes, and I'm in northern New Jersey. I do general ophthalmology, and I specialize in cornea.
And today we have a special guest, Adam Friend. Adam is a partner with John in New Jersey. And we're going to let Adam give his bio and then roll right into cross-linking for keratoconus, which is a really interesting topic. Adam, take it away.
Thanks, gentlemen. I unfortunately did not have the luck of training with you guys at Einstein, but I did attend Albert Einstein Medical School. So it's a privilege to be part of Einstein's Eyes today. Thank you so much. And as you mentioned, I am a cornea specialist in New Jersey, partner with John. So today, what we're talking about is corneal cross-linking. This is one of the treatments I do for patients, and the cornea is the clear structure in the front of your eye. Normally, it's shaped like a sphere, but there's certain conditions where the cornea steepens and becomes more shaped like a cone. The most well-known is keratoconus, but we also see it after patients have surgery to correct their nearsightedness. They get a condition, potentially can get a condition called ectasia, where the cornea loses its shape and becomes cone-shaped as well. So this can cause blurry, distorted vision. That's in the beginning, it's can still be corrected sometimes with a contact lens, but eventually the patient deteriorates to the point where you're looking at needing a hard contact lens. And in the worst cases, it advances to needing a corneal transplant. So some of the warning signs that a patient may experience, that the prescription keeps getting increased astigmatism over time, that even with an updated prescription, they're still not seeing very well. One thing that we see commonly is that patients will be rubbing their eyes frequently or very vigorously. We see this with people with bad allergies. So you definitely want to try and reduce that, or use oral or pills, antihistamines to control your allergies. And this condition we see mostly in your teens and 20s when the cornea is very elastic. As we get older, the cornea starts to stiffen on its own, and it's less common. So just like your joints get more stiff, your cornea gets more stiff too. When you see your eye doctor, the eye doctor can see on the microscope that there might be little stress lines in the cornea that we call striae. But the most common way that we diagnose this condition is with the topography, the map of the cornea, where it shows the telltale sign of steepening in the center to lower part of the cornea. So when a patient has this condition and we're worried about it progressing, I do a treatment called corneal cross-linking, and I use the iLink procedure. This is a device made by Glaukos, which is the only FDA-approved treatment of cross-linking. Therefore, I know that I'm using the safest and most effective treatment. So this is done in an office setting. It's not done in an operating room. And what it's designed to do is form stronger bonds between the collagen fibers, the proteins that make up the structure of the cornea. And it occurs because of a chemical reaction. The reactions between riboflavin, which is also known as vitamin B2, oxygen, and ultraviolet light. Great. So the first step to the procedure is I use an instrument that removes the cells on the surface of the cornea. And we do this so that the riboflavin can be absorbed by the cornea better. Once the surface layer is removed, we lay a patient down and we put them in this position with that instrument. And the riboflavin, we put 1 drop every 2 minutes on the eye for 30 minutes. And we're doing this to make sure that the cornea is completely saturated with the riboflavin and that it swells to a certain thickness. We don't want the cornea to be too thin, because then we're worried that the ultraviolet light might go deeper inside and damage the internal structures of the eye. So once we've reached that safe thickness, the next step is what's being shown here, where the ultraviolet light is being focused on the cornea, and that takes place for another 30 minutes. Once that's done, this instrument, the speculum, is removed from the eye. Protective bandage contact lens is placed on the eye, and then the patient starts using postoperative drops. So the first day, the patient will normally experience some discomfort because it's the same feeling as getting a scratched cornea. The other thing that you'll notice is that there'll be blurriness. The pain, though, usually is gone after the first day, and the blurriness clears up after about a week. And at that time, we remove the contact lens. The patient will then use the postoperative drops for another 2 to 3 months while the cornea settles into its new shape. And that is how we do cross-linking.
Perfect, perfect. Well, thank you. That was great. That was great. It was very informative. I think our audience will enjoy that. John, do you have any comments?
Yeah, a couple of questions. So Adam's done actually done this procedure on many of my patients. Great results. I've been amazed. You know, I tell patients with keratoconus, when I used to see patients 20 years ago, there was nothing to say to them. We just said, hey, let's hope it doesn't progress. And we would hope some of them wouldn't, and then some wouldn't. They'd ultimately need stronger treatments. And now there's this wonderful treatment that stops the progression if you catch it early. What are the risks you tell your patients of the cross-linking?
Well, fortunately, it is a low-risk procedure, but probably the most risky part of it is until that surface layer heals over, there's a risk of infection, because the surface layer of your eyes is a really good defense against bacteria and other invasive organisms. So one of the postoperative drops we use is a strong antibiotic drop. So once that heals over, the risk of the infection is pretty much done. And then there's probably the next largest risk is that there'll be a haziness in the cornea where the treatment has occurred. So one of the other postoperative drops that I use are vital tears made from a patient's blood. Takes the serum out of the blood, which has very strong healing properties and can lower the risk of that haze developing.
You know, that's funny, because we have a video on vital tears and autologous serum by the CEO, Raj Shulman.
Wow.
Yeah.
Yeah, it's an amazing product. We swear by it.
Do you give Tylenol 3 after this or no?
So yes, so I mentioned before that the first day is an uncomfortable day. So I will give Tylenol with codeine, Tylenol number 3, to help ease the pain. And it's really a wide range of pain, where some people say, oh, you made too much of it, it was nothing at all. And other people do tell me they suffered that day.
Great.
Fantastic. Well, listen, this was really informative. I enjoyed it. I learned something. Adam, we're going to have you come back and talk about another topic involving the cornea, your specialty. You're an expert. John, thanks again, and we'll see you guys on it.